I'm going to talk fairly quickly through kind of applied public health. Public health is a clinical practice at the end of the day, and it's although it lives in a basic science department, I think you're seeing it in action these days. One of the things that we're working on night and day is epidemiologic modeling to predict the course of the COVID-19 pandemic. There are a host of people who are working on these things, and I'll come back to them at the end, but we're doing this in collaboration with the Division of Biostatistics, the School of Public Health, and the Proctor Foundation, the division of my division of infectious disease and global epidemiology. We're doing it very specifically for the San Francisco Department of Public Health, although we're starting to go out to some of the other local health departments. What we're trying to do is design a robust surveillance system for COVID-19 and construct models with particular reference to incidence of cases, prevalence of cases, healthcare utilization by cases, the effects of public health interventions on incidence, and improving parameters for estimating, improving parameter estimates needed to construct models in other jurisdictions. The next one, please. So I'm putting in fake models. I'm not going to show, we're still messing with our models, and the city is going to release them when they're released, not us. But we're trying to put together incidence models. And one model we've constructed is anchored, it's done prospectively. Paul Wesson in the division of, in the Department of Epidemiology and Biostatistics has been especially central to this. So one way to do this is to anchor on the date that it's introduced, and then use the effective reproductive number, which we have from China, and then also how it changes over time. To move from a curve that's this high peaked curve to a flattened curve means that the basic, that the effective reproductive number has changed. The other thing we anchor this on is the period from infection to initial viral shedding, which is on the order of 3.5 days. And we actually think we're getting pretty close to being able to estimate what's going on in terms of constructing these models forward. Traditionally, mathematical models are done without a lot of real data. And so this is taking real data and putting it in and trying to understand how this should be multiplying in the Bay Area and in the city. The next one, please. The other is to try and construct prevalence and healthcare utilization estimates. In this one, we want to anchor on known numbers, which we could put into time series. If this were a disease that were where everyone was clearly infected and everyone got diagnosed and everyone got reported, like measles, this would not be that difficult to do. But in a disease where, say, between 20 and only 20 to 40% of people are being diagnosed, with the rest mildly symptomatic and asymptomatic, there's a lot of loose parameters. So the only ones that we really have as hard numbers are the number of reported cases, which is very dependent on how much testing is available. We saw a jump over the last, in the last 24 hours, which was probably largely a function of testing, although we're going to have to see. But the other hard number we have are the number of inpatients, number of inpatient admissions. That's a real number, because that's going to, people who are sick enough to get to be inpatients are going to be pretty constant over time. So the parameters we use are the effective reproductive numbers and changes over time to look at the effects of public health interventions, the ratio between persons under investigation and confirmed cases, and we can use that to estimate the maximum bed and ICU usage as we're going forward. And so that's what we're working on. This is from the infamous Imperial College model that people have heard about, where basically this is just a straight up mathematical function that's based on doubling time. I ran this with a doubling time of 4 days and 5 days and got a difference of 10,000 cases a day in San Francisco. So just to let you know how sensitive these things are. The next slide, please. Next slide, please. Travis Porco at the Proctor Foundation, also a member of the Department of Epidemiology, and biostatistics has done a lot of modeling and is still doing a lot of modeling. It's still doing a lot of modeling about effects of various interventions. We modeled out school closures for the city. This is based off of models for measles transmission. We can include other parameters like workplace closures, daycare closures, contact investigations, and come up with scenarios for what kind of bump to expect if you close schools. This is a very, don't pay any attention to these numbers. All we're trying to say here is that with school closures, you push the curve to the right. And the final one, please. So the real thing we get down to is surveillance. And in public health, you need to know what's going on. We need to be able to diagnose what's going on in a population in order to intervene. So think of it as diagnostics and therapeutics. The more reliable the underlying data, the more accurate the models we can construct, which is what we're going to base a variety of decisions on, or the city will base a variety of decisions on. Those are inpatients with confirmed disease, reported cases, and the ratios between positive cases and people who test negative. We would also eventually like to move to large representative serological surveys to understand epidemic dynamics. Unfortunately, given the crush for clinical clinical testing, the kinds of studies and the study sample size that would be needed is just prohibitive to achieve the kind of point estimates that we'd like to have. One really interesting thing that's come online from Mark Pletcher, and all of those for Dr. Algan and Marcus from cardiology, is to repurpose a big digital e-cohort study, which is studying cardiovascular disease. This is called the Citizen Scientist program. And it's looking for what has been added in, it's actually gone live today, is to ask people who are enrolled in it to report symptoms of cough, fever, shortness of breath, basically moving to a syndromic case definition. They have daily surveys. They get these data daily, and there's geolocation via the smartphone app. There are currently 300,000 people enrolled in this throughout the world, most in the US. But we're hoping to get as many as 10,000 people in San Francisco. This is crude stuff. It's kind of big picture stuff. We also have influenza surveillance that we're trying to repurpose for this as well. But that gives you an idea of what we're working on in modeling. I'd like to give shout outs to, in no particular order, Paul Wesson, Travis Porco, Hugh Sturrock, Adam Bennett, Krisha Linden, Maya Peterson from Berkeley, Dan Kelly, and then also from the City Health Department, Willie McFarland and Susan Buckbinder. Borrow a term from architecture, we shredded out a draft of a seroprevalence PCR prevalence study over the weekend, and then finally ended up walking away because of kind of competing demands for testing systems and the sample size that would be required. So we're pretty happy with where things are going. I think we're in reasonable position to predict what's going to happen, and we're just going to have to kind of follow it forward over time. Thank you.